Uh, so I think uh, all of us don't like to see a patient after cataract surgery looking like this, particularly in patients with uveitis. And many of our patients have cataract due to steroids or due to the inflammation itself. So we need to have certain preoperative considerations before considering cataract surgery. The main aim of our procedures or preparations is to optimize the outcomes of the cataract surgery and to minimize the complications. The most critical step we always like to step. You start to count 3 months from inactive disease. If you don't have records, you have to wait for 3 months before considering cataract surgery. A small amount of residual flare is acceptable because sometimes you cannot bring the flare to zero, but cells are almost unacceptable. You have to control the inflammation. Sometimes you have chronic disruption of the blood aqueous barrier, so you cannot bring the flare to zero. You have always a trace flare or 1+ flare. So before doing anything, you have to assess the eye because some of these situations may interfere with the surgery itself or the outcome of the surgery. You have to assess for band keratopathy, which is very common, especially in the children. We are seeing this more in the children with the GIA. And the good thing is that this band keratopathy can be easily treated with EDITA, and it is available, because if you don't treat well, you will not be able to see during your cataract surgery well. You have to assess for posterior synechia, the extent of posterior synechia, because you may need to prepare yourself having iris hooks or to have something to deal with this narrow pupil. Iris atrophy and vascular fragility. This is very important, and I will show you a couple of cases at the end of this talk. Because when you use hooks, or you may lead to sphincter rupture, or if you have fragile blood vessels, you may have hyphema. Pupillary membranes also are common because of the inflammation, and they need to be peeled before proceeding with the usual cataract surgery and the capsulorhexis. The small myotic pupil also, you should pay attention to it, because you may have problems with dilatation, and if you don't have good or proper dilatation of the pupil, this will make your surgeries difficult. Vitreous haze is also important. We have to assess for the vitreous haze. If you have white cataract, as usual in our cases, you have to use B-scan to check the condition of the vitreous. Of course, we are relying now more on imaging to detect earlier any macular changes or vitreous changes or retinal changes which may interfere with the results of your surgery. We are discussing with our colleagues the use of OCT before cataract surgery. I think most of our colleagues now are using OCT even before cataract surgery, not for the uveitic patients, to avoid post-operative surprises. And if this is the case in the routine cataract surgery, I think it is more applicable in uveitis, because our cases are more prone to have cystoid macular edema, epiretinal membranes, and the macular pathology. So we have seen several cases of cataract surgery done by eminent cataract surgeons, and after surgery they were surprised by the presence of macular edema or epiretinal membranes. So it is very important to pay attention to this point. Fluorescein angiography is also important if you have opaque media to show you the macular edema or the retinal vasculitis, which is very important also if the patient has retinal vasculitis and retinal ischemia. B-scan, as we mentioned, is mandatory to show the vitritis or the presence of retinal detachment, which are common in fact in cases of uveitis. UPM also is being used increasingly in cases of uveitis, and particularly in the cases of parasitic granuloma, and they are important also before planning for the surgery if you have a ciliary body granuloma, if you have granuloma in other sites. So you have to be careful before doing cataract surgery in such patients. This is a very important machine, in fact, and I had the opportunity to work with this machine for 10 years during my training. The PAM, or potential acuity meter, it's very important to predict the visual acuity and to have realistic expectations with your patients before doing cataract surgery. Again, control of inflammation is the most critical point. We have to control inflammation by all means before cataract surgery, starting from the oral steroids, topical steroids, and injections, and we will go over this one by one. The topical steroids, we can use topical steroids frequently 1 week before the surgery, provided the patient is quiet. As we mentioned, we can use them every 2 hours 1 week before surgery. We can use them for more time if the uveitis was severe. Again, we are not allowed to do surgery during active inflammation. The second is the oral steroids. We usually perform cataract surgery while our patients on steroids, and even if the patient on low dose steroids, we increase it, and the practice variable, but I myself don't go over 40 milligrams of steroids. This is particularly important in the severe cases of uveitis, especially the GIA. The GIA is associated with severe complications, and in fact, the most difficult and the worst prognosis I usually face in GIA. Also, cases of granulomatous uveitis, intermediate uveitis, and cases of cystoid macular edema, they need to be heavily immunosuppressed before doing cataract surgery. So there are some other practices. For example, in patients who are diabetic or cannot peer oral steroids for a long time, we can give them single injection of pulse steroid, which is single injection of methylprednisolone acetate. Again, another option for delivering high dose of steroids into the eye is the periocular injection. I like this method very much because we can use it pre-operative, intraoperative, and post-operative, and you provide high dose of steroid into the site of the inflammation, so you can use it before the surgery. The intravitreal steroids. In fact, there are some literature about intravitreal triamcinolone acetonide, but I never inject, and I will never inject, because it is associated with severe complications, associated with high increase in the intraocular pressure. And even I asked our retina colleagues, they are not using intravitreal triamcinolone injection for control of inflammation. On the other hand, we can use the dexamethasone implant, which I think is very effective, and I have used several of them in different uveitic indications, and they have high safety profile instead of intravitreal triamcinolone. And this is particularly important for patients with cystoid macular edema or posterior uveitis. Coming to the non-steroidal anti-inflammatory drugs, I think these medications, we are not using them more frequently. I guess because they are weak. Imagine if you are giving a patient pulse steroid and intravitreal steroid, and I think they will not respond to these weak medications, but in some cases, I think we may revert to them. For example, if you have a patient with high intraocular pressure which cannot afford steroids, you can give them. They are safe medications. And our colleagues, we have a lecture before, and our colleague from Saudi, they are using this drops frequently to control uveitis, and I think it deserves you. We can try to apply them, particularly in the patients who are not responding well to other medications or who have high intraocular pressure. Again, the immunomodulatory therapy. This is a very important point to highlight here. In the general surgery, the rheumatologists usually ask the patient to stop the immunosuppressive therapy because they are afraid of delayed healing. But in ophthalmology, the reverse is true. we ask our patients to stick and comply to the medications because we need the maximum control of inflammation. Because I have seen this in my patients. They are coming telling me, my rheumatologist asked me to stop the medication or decrease the medication before cataract surgery, and this is absolutely wrong. We have to do the reverse exactly to maximize the anti-inflammatory medication. There are some specific uveitis types that we have to pay attention to. For example, in cases of Fox uveitis, it is usually difficult to bring them to 0 cells and flare. I myself don't like to operate in a patient with cells, but some of our colleagues can tolerate few cells in cases of Fox, and they do surgery, and it depends on the situation. But usually I can accept flare, but I cannot accept cells, and I respect the opinion of other colleagues. Regarding the infection, this is another special situation we have to pay attention to. In the cases of herpetic uveitis or viral uveitis, you have to give the specific antiviral therapy before surgery. 1 to 2 weeks before surgery, you give the full dose, and then you put the patient on a maintenance dose for several weeks. Regarding other infections, the toxoplasmosis, the literature is not rigid, but you can give prophylactic trimethoprim sulfamethoxazole combination. In HIV, the patient usually should be asked to continue antiretroviral therapy. In cases of syphilis and TB, there are no standardized protocol as far as I know, and because I think, for example, the treatment of TB is prolonged, so you cannot initiate a patient on a treatment of antitubercular medication as a prophylaxis for 3 or 6 months just for undergoing cataract surgery. So we have before doing the surgery to have some risk stratification. I think all the uveitis cases are highly risk, except for some few conditions on the right, which is the Fox heterochromic iridocyclitis and well-controlled uveitis, as we mentioned, and the older age. And we have also to discuss with your patient the realistic expectations. And you have to tell them usually that this is not a routine cataract surgery, and the results can be affected by the pre-existing macular pathology, optic nerve damage, or posterior segment complications. And explain the risk to the patient. I usually tell my patients that there is a risk of post-operative inflammation. You may have recurrence of uveitis, and I usually stress on this point. The incidence of cystoid macular edema also is higher in these patients, and the patients should be aware of this. And the posterior capsular ossification is also common, and we have published a paper about the incidence of PCO in patients following uveitic cataract surgery, and we found like 30% occurring, but they were not visually significant. This is important because most of the patients develop PCO, but it's not interfering with the vision, so there is no problem. So this is the cases I have seen the couple of weeks ago. This is one of our cases. We did surgery for her 2 weeks ago, and the pupil was myosed, and there was posterior synechia, extensive posterior synechia. We tried to release, but we had to use iris hooks. And after the surgery, the iris looked like this. Unfortunately, she developed sphincter rupture. This was unavoidable, in fact, because the pupil was not dilating. And we used iris hooks frequently, but this is not happening a lot. But sometimes when the pupil is tight, too tight, you may induce rupture of the sphincter. And I'm keeping following the patient. She's complaining of photophobia, but the vision is nice. But I'm telling her that she will adapt, and we are keep looking at her. The other patient also is a decent lady, and she had a very good surgery, uneventful surgery. This was 2 weeks ago, and we did the routine peripheral iridotomy, and after the surgery, after the second post-operative day, she came to me with this large blood clot. and high FEMA and corneal staining, and the vision was, of course, affected too much because almost the position is central and the IOL was obfuscated from the reaction. I asked her to wait for 3 days, and after 3 days the clot didn't resolve, and we had to do a wash, and we did surgical wash for her 2 days ago. So the cataract surgery in uveitis is not an easy task, in fact, and you have to take all your precautions as much as you can, but you still have the possibility of having some complications, and the good thing if you are able to deal with your complication, وطبعا ربنا يستر معنا إن شاء الله دايما. So the summary of the preoperative checklist, as we mentioned again, you have to wait at least for 3 months of quiescence before doing the surgery. You have to use all available anti-inflammatory medications, topical, systemic, and you have to keep and maintain your immunosuppressive therapy. And in cases of infectious uveitis, you have to take the proper antimicrobial therapy and the proper antimicrobial cover. So again, complete control of inflammation is a key, and be prepared to complications after cataract surgery. And finally, thank you very much.